Sameh for keeping in time.
May we call upon Dr. Ihab Abdo. He is going to talk about ruptured cardiac hydated cyst as a rare cause of systemic emboli.
Assalamu alaikum wa rahmatullahi wa barakatuh. Really, I'm happy to be here today, and I would like to thank the organizing committee for this for this nice arrangement. Actually, I was asked by many of our colleagues to represent this case again with more details, so I would like to give me full opportunity to present the case, please. This is Mr. N. Mr. N, he's 31 years old, a Nepali patient. He was working at one of the shops nearby King Khalid Hospital, Ha'il Kingdom of Saudi Arabia. He brought with his friends to our ER and they found him collapsed at the toilet. Actually, this patient, upon arrival to the emergency department, he was flushed, cyanosed, not communicative, not obeying commands. Sooner, the patient developed skin rash, urticaria-like, puffy face, swollen lips, and his blood pressure was unrecordable. So, Code Blue announced in ER, and Code Blue team started to resuscitate the patient. They intubated, and the patient invented, given adrenaline and noradrenaline, and then the patient finally shifted to the ICU. In the ICU, they requested for CT scan brain, and they requested for blood samples for toxicology and pan-septic screening. And actually, the blood samples for toxicology and pan-septic screening were negative. And the CT brain, there was no gross abnormality in CT brain except as you see, a small hypodense focal lesion in the left globe. It was consistent with possible foreign body. Actually, I received the call after 2 hours of the patient admission in ICU that Dr. Ihab, we have a patient like this, but while we are doing assessment for the patient, we found that the distal pulses of the patient were not palpable, pedal pulses, I mean, and the patient extremities are cold, and we cannot record the oxygen saturation. So we went there and we assessed the patient, and we found that the distal pulses are not palpable, even the popliteal and even the femoral pulses are not there. Then the oxygen saturation was not recordable, and the distal extremities were cold, so we requested for CT angiography. As you see here, this is the abdominal aorta, and this is the both iliac artery. There is total occlusion of the distal aorto-iliac vasculature. So we started to give the patient heparin, and we requested for cardiac assessment, and then we shifted the patient to OR for bilateral femoral embolectomy. After the procedure, what I would like to mention that we faced a little resistance while we are removing the emboli. And the surprise with the nature of the emboli, it was like a thick membranes, as you see. And we expected that we make like an intimal injury. So we asked the ICU team to keep an eye for the hemodynamics of the patient. And the emboli sent for histopathology examination. Post-operatively, the patient regained his distal perfusion, but 2 hours later, we received the second call from the same intensivist and for the same patient. That Dr. Ihab, now we started to reassess the patient again, and we found the left upper limb distal pulsations are not there. and the patient left upper limb is cold. So come please to assess the patient. We asked for duplex ultrasound that revealed the patient has brachial block. So we requested to shift the patient to OR for brachial embolectomy. The surprise was there is the same embolic material that we removed from the femoral artery. It was the same from the brachial artery. It was the same nature of the emboli. Later, the same night, the general surgeon received a call from the intensivist that please, we have the patient like this, but now the patient abdomen is tense. There is tenderness of the right hepatic colonic flexure and left splenic flexure. So the general surgeons advised for double contrast CT. The double contrast CT was not consistent with superior mesenteric artery occlusion, nor definitive for bowel ischemia. But the next day, the patient abdomen became more tense with increased CK and worsening renal profile with low urine output and tender abdomen, so the general surgeon decided to operate upon him. And this is the picture intraoperatively. There was no anything abnormal except a small area of serosal injury in the proximal jejunum. So they decided to have a second look after 24 to 48 hours. And this is the second look. Second look was taken negative with no more serosal injury. With fallopian abdominal closure, patient shifted back to ICU. So we started to have a meeting, what are the possibilities? Going back to the history that the patient presented with anaphylaxis, and post-anaphylaxis, the patient have multiple ischemic events in different areas, so it may be ruptured hydated cyst, or ruptured cyst, intravascular, I mean. Or the second possibility, it was metastatizing atrial myxoma. So we asked for urgent cardiology review by a senior consultant. He came and he started to do transesophageal and transthoracic echo. And as you see here, there is a flap and remnants of a ruptured cyst in the left ventricle. So this is the main source of the emboli. You can see here, this is the echo live. You can see here the remnant of the flap of the ruptured cyst in the left ventricle. The histopathology report was collected and was consistent with hydated cyst, so we started to give the patient anti-echinococcal chemotherapy, which is albendazole. Albendazole started. Patient was more stable and he started to off IV or epinephrine. He was on moderate ventilatory setting, passing good volume of urine. He was conscious and then got extubated. Patient extubation, post-extubation, patient transferred to the surgical observation room. Fortunately, the patient survived. But there is still a question, and I would like to ask the floor about this. This is not the end of the story. Still, the patient, he survived, but still we have a flap in the left ventricle. Is it to be excised, or we can continue with medical treatment?
Could I have 2 minutes enough?
1 minute.
1 minute? Okay.
As I said, it is not the end of the story. We have question. The flap inside the left ventricle, is it to be excised surgical by open heart surgery? Or we can continue with medical treatment and follow the patient by a frequent echocardiography. Actually, we communicated with the higher hospital in Kingdom Saudi Arabia, which is King Faisal, and they are divided into 2 teams. Some, they have opinion we should excise the lesion by open heart surgery. Why? They said that this lesion may interfere with the conductivity of the heart. It may affect the function of the ventricle, of the myocardium. And also it may recur again, it may adhere and make cyst again. So they requested to excite the other, like the parasitologist, they requested to follow the patient by medical treatment and then for frequent echocardiography to see if there is new evidence. We reviewed the literature and we didn't find any data that can support any of the two opinions. But unfortunately, the patient asked to seek second medical advice in his country, and he left the kingdom. Thank you.
Thank you, Dr. Nehad. Very nice case.